Hello, everyone. I'm Dr. Carmen Pugliafito, and I'm here today with Professor David Sarraf of the UCLA Stein Eye Institute at UCLA. Welcome to Retina Synthesis, David.
Thanks for having me. Appreciate it.
So you gave a fascinating talk at Angiogenesis 2022 entitled Subretinal Fluid in Neovascular AMD, Protective, Fact, or Fallacy? So why is this a pressing issue in your view of treatment of wet macular degeneration?
Well, there have been a lot of trials recently, a lot of papers written that have kind of focused on this association of baseline and final outcome fluid being associated with better visual outcomes. And I think it led to this misconception that fluid was actually protective and actually could be mediating better vision, perhaps by nourishing the photoreceptors. That's one concept that I've heard to explain that association. But I think if you look at some other pathways of fluid leakage, you begin to understand that it's a real association, but it relates to other pathoanatomical concepts. So that fluid, I think, can be an association of good vision, but it doesn't mean that we necessarily should leave it there. It still needs to be treated, but it can be an indicator of the health of the RPE. And that's the message in a nutshell.
So what about the pathophysiology of SRF?
So I think when you see SRF, at these 1 and 2 year outcomes, it probably is an indicator that the RPE is still viable. The pump is still working. It may not be perfect, but it's still functioning. And so when we see fluid there, it's probably a factor of both the RPE pump working, but not at an optimal level, but also a reflection of underlying neovascularization, which we also know can sustain and nourish the RPE. When the RPE is gone and it's atrophic, we showed many examples in that talk that show that subretinal fluid then resolves, because then you lose that barrier. There's a normal bulk direction of flow from the vitreous to the choroid. And when you lose the RPE completely, as with GA or what we refer to now as C-RORA, that fluid just passes with facility into the choroid. And that's why I think you see poor visual outcomes when there's no fluid at the 1 and 2 year outcomes. I think at the 1 and 2 year visits, that's an indicator that the RPE is lost and the underlying neovascular proliferation is also absent.
Now, we all agree that intraretinal fluid is not good.
Yeah, intraretinal fluid's a little bit different. We see intraretinal fluid when we have atrophy again. So it's a similar concept, but when we tend to see intraretinal cysts when atrophy is present. And this may relate to the loss of Mueller cells. So whereas subretinal fluid resolves with end-stage atrophy, GA and C-RORA, we can develop intraretinal cysts as a reflection of Mueller cell loss. And so that is actually the type of fluid when we see atrophy present. We don't see subretinal fluid, but we see these degenerative cysts. And that may explain the many papers that have shown a correlation of intraretinal fluid at 1 and 2 years with worse visual outcomes.
So in the large studies, the CAT, the IVAN, Harvard trials, what can we glean from those 3 studies about SRF?
Well, I think what we learned from those studies is that, in fact, yes, there is consistent association of subretinal fluid with better visual outcomes. And that's not because subretinal fluid is protective. That's just an indicator that you have a viable RPE pump that is trying to reduce fluid from the subretinal space. And there's also underlying neovascularization, which may be active and paradoxically sustaining the RPE and nourishing it, and that may be overwhelming the RPE pump. When we lose that fluid, it's usually a sign at these 1 and 2 year outcomes that the RPE barrier is lost and the pump is no longer there, and there's no longer a barrier to fluid, bulk fluid outflow into the choroid.
In the Hawk and Harrier trials, there was an analysis of IRF and subretinal fluid, and the conclusion is that this was seen with both brolucizumab and aflibercept, that drying was good for vision.
Yeah, I still think that we see that this is, I think the main gist of the talk that I gave is that subretinal fluid still needs to be treated. And it's still important to deturgest the retina, especially if there are associated features of neovascularization like SHREM or heme, or if there's progressive fluid. I think if you have mild, persistent, shallow fluid that is not progressing and there are no other signs of active neovascularization, perhaps that fluid can be observed. But if you see progressive fluid, certainly that needs to be treated. There's no benefit in observing progressive subretinal fluid. And I think ultimately our goal is to deturgest the retina. But we have to understand these nuances in terms of fluid dynamics, degenerative cysts, overlying areas of end-stage atrophy. Those can be monitored. Those don't need to be treated. And you'll know that because they don't typically progress with the observation. And that's what we've noted too with subretinal fluid. If it doesn't progress, it probably can be observed. But if it progresses, it should be treated for sure.
Any observations about subretinal fluid and diabetic retinopathy, macular edema?
Well, that's an interesting consideration. You do get subretinal fluid with DME, and we've talked about this. We wrote a paper, 1 or 2 different papers looking at subretinal fluid. I think you see it in 2 different situations. One, when there's massive diabetic macular edema, that will, I think, overwhelm the RPE pump, and you'll see a gravitation of that fluid into the subretinal space. And usually it'll be associated with severe diffuse CME and large areas of subretinal fluid. There is another situation, though, when you see small pockets of central fluid, and we've referred to this as an alteration in the cone bouquet. And what happens in those situations is when the retina swells or there's traction on the retina, this pulls on the Mueller cells, which almost act like shock absorbers or springs, and it causes that central bouquet to elevate. So in many various situations, when there's swelling or traction in the retina, you'll get these small pockets of subretinal fluid that may just be a manifestation or a reflection of Mueller cell Mueller cell stretching, causing that little pocket to elevate. But in the situations where you have more widespread subretinal fluid, that may be an association of severe diabetic macular edema.
So in looking at new pharmaceutical agents, is persistence of SRF still an important variable to be examined?
Yeah, persistent SRF it's a kind of this is another concept that we've talked about and we've studied. Again, I think the RPE pump, the choroid, neovascularization, all these different pathways are important to consider when you see persistent subretinal fluid. The typical scenario in a patient with neovascularization is that you have active neovascularization. It's leaking across the RPE. The RPE is working overtime, but it's a little bit overwhelmed. And there's some residual subretinal fluid that's still persistent. If that's predominantly the result of neovascularization, that fluid will progress and you'll need to treat it if it progresses or if it's significant or associated with other mediators of neovascularization. But there are situations in both non-neovascular and neovascular AMD where you can get fluid not because of neovascularization. It can be because of other pathways such as RPE pump failure, as I've already discussed at length, or pachychoroid disease. That can be a factor too to consider. So when you see persistent subretinal fluid, it shouldn't be a knee-jerk reaction to inject. You have to consider these other pathways.
Well, David, this has been a fascinating discussion about issues that have been on the mind of clinicians for many years and will continue Thanks for joining us on retina synthesis.
I appreciate it. Thank you for having me, Carmen.